Okay, let's set the scene. You're the junior resident on call. It's 3 a.m. The pager screams, "Code stroke." The patient's on the way to the scanner, and your attending's on the phone, needing a read now. What do you do? Well, this is your high-yield guide for navigating that exact moment. So let's dive right in. We're going to build a 6-step diagnostic roadmap together. First, we'll tackle that critical first question. Then we'll decode the classic arterial stroke, look at other vascular emergencies, deal with malformations, spot the mimics, and wrap up with some clinical pearls that are going to make you look like a rock star on call. So the first thing you have to do, absolutely have to, when you see an acute neurodeficit is build a super fast decision tree. You've got to figure out which of the 3 big vascular catastrophes you're looking at. Is it an artery, a vein, or is it spasm?
Now, this table is where the magic happens. Look at how we can tell these apart. Arterial strokes, they give you pure cytotoxic edema, and it happens immediately. Vasospasm, on the far right, that's a delayed problem. But check out that middle column for venous stroke. It's the odd one out. It gives you a mix of both vasogenic and cytotoxic edema. That combination, well, that's your golden ticket right there.
Let's really hammer this point home. If you see that leaky interstitial vasogenic edema that then develops cytotoxic edema on top of it, you need to be thinking venous infarct. And this is so critical because these have a way higher risk of bleeding compared to your standard arterial strokes.
All right, let's shift gears to the most common thing you're going to see, the acute arterial infarct. We absolutely need to know what this looks like hour by hour. This timeline is your cheat sheet for dating a stroke. In those first 6 hours, the hyperacute phase, your diffusion-weighted images are going to be screaming bright. But here's the kicker. Your T2 and flare images might look totally normal. That mismatch between a bright DWI and a normal T2 is the classic textbook sign of a very early stroke. After about 6 hours, T2 finally catches up and turns bright too. But hey, before you even get to an MRI, your first look is going to be a non-contrast CT, and you need to be looking for this, the dense MCA sign. It is literally the clot itself, sitting in the artery. It's so packed with red blood cells that it looks brighter than the other vessels. This is one of the very first and most specific signs of a major large vessel occlusion you can see. So how do you actually quantify that early damage on CT? That's where the aspect score comes in. It's pretty simple, really. You start with a perfect score of 10, and you subtract 1 point for each of 10 key areas in the MCA territory that shows any early signs of stroke. So a high score is good. It means less brain is involved and predicts a much better outcome. Now, speaking of treatment, before you even think about giving TPA, the clot buster, you have to weigh the risk of causing a bleed. So you have to check for these red flags right here. A huge territory involved, a clot that's way up in the vessel, a delayed presentation, or poor collateral blood flow. Any of these things dramatically cranks up the risk of that stroke turning into a hemorrhage.
Great. Now let's broaden our differential. Not every vascular emergency is a simple clot. We've got to be ready for things like dissection, venous thrombosis, and vasculitis.
And timing is just absolutely crucial here. On the left, dissection and venous thrombosis, these are immediate events. The wall tears, the clot forms, symptoms start right then and there. But look at the right, vasospasm. It's a delayed reaction. It's a consequence of having blood in the subarachnoid space. And it doesn't even start for a few days, peaking a week or 2 later. You can't mix these up. For dissection, this right here is the money shot. It's called the T1 crescent sign. On your T1-weighted MRI, you'll see this beautiful, bright crescent of blood. That's mechemoglobin. Inside the wall of the vessel itself. It's the classic Aunt Minnie can't-miss finding. And for a venous thrombosis, on a contrast-enhanced CT, you're hunting for the empty delta sign. You see, the walls of the sinus light up with contrast, but the middle where the clot is sitting stays dark. It creates this little triangular filling defect. It's a dead giveaway that you're dealing with a venous problem.
Okay, let's move on to cases where the plumbing was just a little off to begin with. We're talking vascular malformations and aneurysms.
The big thing to get here is the difference between a high-flow AVM and a low-flow DVA. An AVM is this congenital tangle of vessels with a central core, a nidus, and it has a real risk of bleeding. A DVA, on the other hand, is basically just a weird-looking but totally functional vein. It has no nidus, and here's the important part. If a surgeon takes it out thinking it's bad, they've just caused a massive venous stroke.
When you're talking about aneurysms, size and location are everything. I mean, look at this chart. Of course the risk goes up with size, but notice how the posterior circulation bars are taller for every single size. The huge takeaway here is that for any given size, an aneurysm in the back, like at the basilar tip, has a much higher risk of rupturing each year than one in the front.
Okay, so you've nailed the true vascular events. But now for the really tricky part. What if it's not a stroke at all? Let's talk about the great pretenders, the mimics.
I cannot say this enough. A bright spot on a diffusion scan does not automatically mean stroke. So many things can restrict diffusion. The real key to telling them apart is looking at the other sequences. Does it have that classic ring enhancement of an abscess? Is the T2 signal just bizarre, like in CJD or herpes? Is it a solid enhancing mass like lymphoma? You have to put on your detective hat.
Moya moya is just a fantastic example of a chameleon. It's this progressive narrowing of the carotid arteries, but it presents completely differently depending on the patient's age. In kids, that narrowing leads to ischemic strokes in those vulnerable watershed areas. But in adults, it's the fragile new collateral vessels, that classic puff of smoke you see on an angiogram, that are likely to rupture and cause a bleed.
All right, you made it. We're at the final section. Let's cover a few advanced concepts that are really going to set you apart from the pack.
Perfusion imaging is all about one thing: finding brain that we can still save. Think of it like a highway traffic jam. The cerebral blood flow, or CBF, is low, that's the traffic jam itself, but if the cerebral blood volume, the CVV, is normal or even high, it just means all the cars are still on the road, waiting. That brain is alive, it's just congested. That's the penumbra. But if the CVV is also low, the cars are gone, the road is empty, that tissue is dead. That's your infarct core.
Now let me tell you about a classic trap. It's called crossed cerebellar diastases. You'll look at a PET scan, you'll see a cold spot in one side of the cerebellum, and you'll think, aha, that's where the problem is. Wrong. The cerebellum is totally fine. The real problem is a giant stroke or tumor in the opposite cerebrum. It's cut the lines of communication, and the perfectly healthy cerebellum has just shut down metabolically. Remember, the problem isn't where you see it.
And finally, a super practical pearl about watershed infarcts. The pattern tells you the cause. If a patient's blood pressure totally tanks, that's a whole body problem, right? So you get these bilateral infarcts in the border zones on both sides of the brain. But if they have a bad blockage in just one carotid artery, you get a unilateral infarct, right in that border zone between the ACA and MCA on that one side.
So there you have it. We've built the framework. You know how to spot the real vascular emergencies and their chameleons. So the final question for you is, which of these mimics are you going to be most on guard for? Because, catching those, that's what truly separates the novice from the expert.